Bismillahirrahmanirrahim. Welcome to the channel. Today we will try to cover the fungal granulomas of the nose. Don't forget to subscribe the channel so that you are not going to miss any important topic. So uh, this is the fungal granulomas which can affect the nose and paranasal sinuses. This rhinosporiodosis we have already discussed in the video, and the link for that video is there in description box, so you can check it out there. And rest of all these granulomas we will try to cover in today's video. uh, Upper three, as I just mentioned in rhinosporiodosis video as well, that upper three are more common while lower three are rare in case of nose and paranasal sinuses. So we will start with the aspergillosis. Now, Aspergillosis, this species, they have thinner septate hyphae, and these hyphae, they are regularly branching, but they branch at an angle of 45 degree as compared to 90 degree, which happens in other fungal infection, that is mucormycosis. So typical feature of aspergillosis is that it has got a septate hyphae, first thing, and secondly branching is at 45-degree angle instead of 90-degree angle. And there are three subtypes, you can say. One is Aspergillus niger. Then Aspergillus niger, as the name indicates, so it will give you a blackish appearance, while Aspergillus fumigatus and Aspergillus flavus, they will give you yellowish or whitish yellowish, pale yellow appearance. Usually it is seen in those people who handles doves and other captive birds, so they are more prone to get this. And when defense mechanism is already compromised due to the use of antibiotics, corticosteroids, diabetes, HIV, etc., so they are more prone to that. These are the predisposing factors, you can say. And symptoms will be nasal obstruction will be there with sneezing and watery nasal discharge, but this watery nasal discharge, it will be moldy, so there will be smell from that discharge. And on examination, nasal mucous membrane will be covered with grayish in case of fumigatus, or black false membrane in case of Aspergillus niger. The infection usually also invades the antrum, and on exploration of the maxillary antrum, a fungus ball containing the semi-solid cheesy white or blackish material. Again, depending upon that it is Aspergillus niger, it will be blackish material. In case of Aspergillus fumigatus, it will be cheesy white appearance, and the uh, fungal ball which will be there in case of maxillary antrum. The organism can be seen on culture examination of the membrane and a special staining for the fungus. The specific treatment will consist of course, repeated cleaning and local application of antifungal agents like 1% aqueous solution of gentian violet or nystatin. In some cases, antifungal amphotericin B, for example, may be given systemically. And when the sinuses are involved, then operative clearance should be performed by functional endoscopic sinus surgery. Now, this mucormycosis, it is an acute invasive fungal infection of the nose and paranasal sinuses, which involves lateral walls and turbinates and then quickly spreads to the orbit, palate, face, and intracranially. These fungi, they become pathogenic when the patient's general resistance has been altered by metabolic disorders or chemotherapeutic agents. For example, he is on anti-cancer therapy or is having diabetes mellitus, leukemia, malnutrition, steroids, anti-metabolic and antibiotic therapy, and in case of severe burns. Again, it has got causative fungi subtypes, that is Mucormycosis, Then there is Absidia corymbataida and Mucormycosis. In these pathology people, they will talk about in detail. And this is the diagrammatic presentation of this mucormycosis. This is an invasive fungal infection, and it can, as you can see, it can go into the orbit or intracranially from the nose and paranasal sinuses. So that's why it is most lethal fungal infection. And why? Because it has got a remarkable affinity for the arteries, first thing, and secondly is that it dissect the internal elastic lamina. This is the internal elastic lamina of in a cross section of a blood vessel. You can see that endothelium is there, and then is tunica media. So in between tunica media and tunica intima, there is this internal elastic lamina. So it dissects this internal elastic lamina from the tunica media, and so it causes the endothelial damage. In a result, there will be thrombosis, and so that the blood vessel is involved, and later on the veins and even the lymphatics are also involved. So the veins and lymphatics can be involved. So there will be a mixed picture of inflammatory and necrotic changes in any given specimen. On examination, the most characteristic rhinological finding is a black necrotic mass resembling a mass of dried clotted blood. Blood, we know it is red, but when it becomes clotted, it is darkish in color. So just it gives the appearance of dry clotted blood. It will be a black necrotic mass which may be filling the nasal cavity and eroding the nasal septum and hard palate even. And sinus radiographs will show thickening of the lining of the sinuses, but there will be no fluid levels, and spotty destruction of the bony walls may be there. This is how external nose may be involved in case of mucormycosis. Under the microscope, the differentiating feature from aspergillosis is that here there will be non-septate hyphae with non-uniform dia, while in case of aspergillosis there will be septate hyphae, and here they will be branching at 90 degree. For example, you can see this is a larger diameter, this hyphae, and it is branching at 90 degree. Then there are small sized also, so not a uniform dia. Some are larger diameter, some are smaller diameter. They are non-septate and they branch at 90 degree. While in case of aspergillosis, there are septate hyphae and they are branching at 45 degree angle. So special stains will help to identify the fungus in tissue sections. X-ray paranasal sinuses or CT scan will be there to rule out the orbital and intracranial extension and to show the involvement of the sinuses and focal bone destruction. MRI for vascular invasion and intracranial extension, because it has an affinity to affect the not only the arteries but veins and lymphatics as well. Treatment will consist of to control the underlying any pathology already if it is there, then systemic amphotericin B and surgical debridement definitely is required because there will be so much necrotic tissue. So that surgical debridement of the affected tissues, and later on once the disease is under control, the generalized principle that any deformity or defect which will be there as a sequelae of the disease, the plastic repair for that accordingly. Candidiasis, this is one of the rare fungal infections affecting the nose and paranasal sinuses. Now, to sum up, some multiple choice questions are there. Now you will have a clear idea of these fungal infections. Now, in case of nose and paranasal sinuses, the most common fungal infection is aspergillosis. Even in external ear, the most common fungal infection is aspergillosis, while the most dreadful, or you can say the most lethal fungal infection of the nose and paranasal sinuses is mucormycosis, because that is an invasive fungal infection and affects the arteries, and not only the arteries but can affect veins and lymphatics as well. So mucormycosis is the most lethal, dreadful, dangerous fungal infection of the nose and paranasal sinuses. Aspergillosis is the most common one, and as far as candidiasis is concerned, this is more common, or the commonest fungal infection in case of oral cavity and oropharynx, while as far as nose and paranasal sinuses is concerned, it is rare. It is also known as oral thrush, so that's why you would have heard the terminology oral thrush. So it is more common in oral cavity and oropharynx. It is caused by a yeast like fungi, which we know the name is Candida albicans. It can involve the skin and the oral cavity. The infection occurs very commonly in the mouth and occasionally in the nose in neglected and marasmic infants and old people. The predisposing factors, again, in case of candidiasis, in patients which are suffering from diabetes mellitus, are someone who is having tuberculosis. As you can see in this X-ray chest, tuberculosis, we know it involves the apices of the lungs more as compared to bases. So this is a typical feature of our finding of uh, tuberculosis on X-ray chest. So predisposing factors includes diabetes mellitus, tuberculosis, are those patients who are having AIDS. Candidiasis presents as the small, discrete, pearly or dirty white patches in the mucous membrane on a red, moist surface. So there will be a whitish patch with a red, moist surface all around, and these patches, they can be easily removed without bleeding. So that is a typical clinical sign. So simple cleaning and painting with 1% aqueous solution of gentian violet or local application of nystatin, which are the antifungal agents. In severe cases, again, amphotericin B or fluocytosine may be given, and any predisposing cause which we just mentioned, like diabetes or tuberculosis or AIDS, that should be sought and corrected. Another rare fungal infection of the nose and paranasal sinuses is histoplasmosis. It is due to the infestation of a yeast-like fungus, that is Histoplasma capsulatum. This granulomatous fungus affects the infants and elderly, and primarily it involves the larynx and the tongue. Infection is by inhalation of infected dust. Nasal findings are accompanied by pulmonary symptoms. So mainly it involves the larynx and the chest. So pulmonary symptoms will be there, and if it affects the nose, nasal findings, they includes ulcer, cough, chest pain, and hoarseness of voice. Again, the diagnosis is by positive skin test and microscopic identification of the fungus confirm the diagnosis. Complete fixation test with 1 to 32 titer is diagnostic, and Sobornard's medium culture can be used. Amphotericin B 1 to 10 milligram per day, progressing to 1 milligram per kg for a total dose of 2 gram for 2 to 3 months period may be required to treat this histoplasmosis. Another rare fungal infection is blastomycosis. Again, it is the infection by Blastomycosis dermatidis, which is an encapsulated yeast-like fungus. It starts in the skin, although primary inhalational infection of the lungs may occur in some cases. The nose is rarely affected, but oronasal mucus involvement is a manifestation of disseminated blastomycosis. The mucosal lesions consist of a papillary hyperplasia with cysts which contain polymorph leukocytes surrounding the organisms. Regional lymph nodes are not usually affected, but dissemination by the bloodstream may produce widespread abscesses in the viscera, especially the lungs, and the specific treatment is again with amphotericin B. So with that, we come to the end of today's discussion, and we have uh, covered the fungal granulomas as well, and you are requested to subscribe the channel, and thank you very much for watching.